the president fired me by tweet. I didn't have any warning. I got the tweet just like everybody else, and my time at VA was over. But, I went to VA not to serve a political party. I'm the only last cabinet member in this country to get 100-0 confirmation from the Senate. In other words, I don't do politics. I didn't sign up for political party loyalty.
From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Health Tech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Thank you and good morning. Good morning, health tech fans. It is a beautiful day here in Connecticut, and I am Jeff Englander. I'm the founder and principal of a firm called Healthcare Strategy Bullpen, and I am joined by Carolyn Brinkerhoff, who is with us from Redox. And Carolyn, I think they're getting sick of my joke about you bringing cloud everywhere. So can you give us a minute on what you do for Redox?
Yes, of course. Thanks, Jeff. It's a beautiful day in California here too. My name is Carolyn Brinkerhoff. I am the Director of Cloud Delivery at Redox. This is a team within our customer success team that focuses specifically on our Nova product. Our Nova product is a full service adapter that allows you to send any kind of healthcare data from any various sources into your cloud hosting provider, whichever one is of your choice. We support normalizing that data into FHIR, whether it comes from any kind of legacy format. I hope that gives you a look into what I do every day, Jeff.
That's great. Thank you very much. And I am honored, and we are honored to be joined by David Shulkin. David is the 9th Secretary of the U.S. Department of Veteran Affairs. David was appointed by President Trump. Prior to that, he served as Undersecretary for Health under President Obama. And David was in charge of the largest U.S. integrated health system with 1,200 sites of care, 9 million veterans, a total of 21 million veterans eligible for care. David was also the CEO of Beth Israel Medical Center in New York and Morristown Medical Center in New Jersey, and the president of the Atlantic Health System, ACO. So David's got a long and distinguished career in healthcare and in helping those with, both high cost and chronic conditions. So David, welcome.
Glad to be with you both today.
So David, as I was looking through some articles, one of the things I saw was you described the VA's superpower as a system that integrates physical, emotional, spiritual, and economic lives. What is it like when you're trying to do that in such a large organization? So what was that like mechanically as you tried to move really and effectively a battleship in healthcare to address those issues?
Well, Jeff, the one thing that you didn't do in your very kind intro was to give the audience a sense of who I am. And the way I define myself primarily is as a doctor. I'm a primary care doctor, and every job I've ever held, whether I've been the CEO of an organization or the secretary of the U.S. Department of Veteran Affairs in the president's cabinet, every week I'd put on a white coat and a stethoscope and go take care of patients. And so when I came from the private sector, I was the CEO at Morristown Medical Center, where I would see patients in New Jersey, and I came to the VA. They said, "Well, you're going skiing." And I said, what kind of federal job is this where they take me skiing? But they took me to Aspen, Colorado, where I was with 400 disabled veterans, and we went adaptive skiing. Many of these veterans had lost legs and arms in Afghanistan with IED explosions. And remember, these are young people who were very athletically fit and very competitive, who all of a sudden are finding themselves in wheelchairs. So we took them out of the wheelchairs. We put them on adaptive skis
great.
down the mountain, and they started to compete again. And I saw the unbelievable power of how, instead of pumping people with drugs and all sorts of things, how this was effective in them regaining some joy in their life and getting them back on track. And I realized the reason they brought me skiing rather than sending me right to clinic was because they wanted to show me that at VA, the definition of health was not the one that I had always had for 30 years as a MD, where I'd say, what's your problem? Why are you here? What's your blood pressure? Let me write a prescription. Here's your test. Come back and see me in 3 months. The way the VA defined health was much broader. It was physical health, of course, but it was emotional, spiritual, psychological, financial, socio, biopsychosocial, perspectives. And so therefore, it really introduced me to a whole different way of looking at how I care for patients than I've ever done in any other time in my career. And if you think about it, the VA is not essentially encumbered in our third-party reimbursement system, which typically doesn't pay for this type of integrative, holistic approach. But every year I would go to Congress and I would say, I'm going to care for this many millions of our veterans. I need this many billions of dollars to do it. And they would give me that money and then pretty much say, go spend it how you think is going to benefit those veterans the most. And that gave us a tremendous amount of freedom, not being stuck in this third-party reimbursement system, but really being able to design the care the way that people need it. And that gave me a whole different way of looking at how healthcare leaders should be helping their populations that they serve.
And as you know, as a physician and as an administrator, what were some of the areas that you thought needed to be attacked first as you started to kind of redesign care?
Well, look, the number one clinical priority that I established for VA was to prevent veteran suicide. And, suicide doesn't happen for just any reason. There's generally underlying causes, whether it's substance abuse, whether it's depression, whether it's PTSD, chronic pain, a number of different issues. So when you tackle these issues, they tend to be biopsychosocial support issues where you need to have both a sort of a medical perspective, a psychological perspective, and a holistic perspective. And so we designed care in teams of interdisciplinary based care. We designed teams that included peer support, very, very important. And then we gave the veterans tools so that they could be active managers of their own health. And when you put those three things together, which frankly, all three are fairly rare in the private sector outside the VA, but when you put those three together in the VA, I think you get some extraordinary results for people.
So let me ask one more, and then I'll let Carolyn get a question in here. There was pressure on you. You had come in, in the earlier administration after a time of scandal in the VA that resulted in performance issues. You had helped write and reform an organization, and there was pressure on you from Congress to privatize the organization. How did you help prove out that some of these initiatives, particularly interdisciplinary teams that you were working on, were getting the value that you were looking for?
Well, Jeff, first of all, let me correct that. There was never pressure from Congress. Okay. Congress in general, there are a few fringe people on the spectrum. I think we all see this today even clearer. The left has a fringe, the right has a fringe. I have no time for those people. The vast, vast majority of members of Congress wanted to do the right thing for veterans and cared deeply about this issue. Almost all have VA facilities in their districts. All of them have veterans as their, member of people who live in their districts. So this was not pressure. This was pressure from the outside groups that had either a belief that government shouldn't be involved in running services, direct services. That's a philosophical belief. Right. Some who I believe were promoting privatization for self-interest. That shouldn't surprise anybody. That's the American way, where people lobby for things that are in their self-interest. And then there were the political appointees who were part of the administration that were a little bit more radical in their approach of taking down the VA. Again, not totally unexpected. Political appointees tend to have a point of view. I just didn't happen to agree with them. I believe that the VA, and I learned this by coming into the system, is doing extraordinary things for our country's veterans. And without the VA system, we would not be able to honor our commitment that we gave to the men and women who raised their hands to defend us. Now, that is not to say that I believe that it should be government only. And
Right.
under my time in VA, we dramatically expanded access into the private sector. Some would say that's privatization. I didn't. I thought that was the way that you best meet the needs of veterans. And I would publish and tell people exactly what the model of care I believed in was, and acted accordingly. And that was to have a system where you put the veteran in the middle. They get access to the type of care that the VA can only provide, I believe. And yet they're not trapped in a system if it's not meeting their needs. So they have access to go outside the VA into the private sector.
So I guess my apologies for mischaracterizing that. What I was trying to get at was, you had a lot of success with what you did. How did you prove out that success?
Well, look, there's, even though I was the secretary and my boss, no doubt, was the president of the United States, I acted as if I only had one boss, and that was the veterans of this country.
Right.
And so whatever I did, particularly since I was the first secretary who was not a veteran, I had never served in the military, I felt it was important for me to always be checking and talking to veterans, veteran groups, family members of veterans, to make sure that I understood what they felt was needed to be done. And so when I wanted to see whether we were on track, I would ask the veterans groups, and I'd make sure that what we're doing was really being perceived, and the impact of what we were doing was positive on them.
Right. Okay. Well, thank you. Carolyn?
Yeah, after all of this really your wonderful stories, my question centers around how you have this history of being a medical doctor, as well as being a leader in the industry, and being able to make change within the VA. Now that you're outside of that role, where do you see your leadership, or do you see responsibility to take your learnings from this new standard of care, this expectation of care that you have found yourself with from working with veterans? Where do you see your responsibility in helping spread that across America outside of the VA? How do you plan to, do you have plans to work on impacting that outside of just the veterans into all of America?
Yeah. Well, Carolyn, when before I went into government, before I went to the VA, I was in the private sector. I was running hospitals, private hospitals, and happy doing it, and thought I would do that the rest of my life. When President Obama asked me to take over the VA, as Jeff was sort of saying, it was a time of national crisis. It was called the VA wait time crisis, where so many veterans were returning from Iraq and Afghanistan. The system was overwhelmed. Veterans were not getting the care they needed, and the country was outraged. As a citizen, I was outraged as well. And when the president asked me to take over, I didn't know much about the VA. I thought I might come in and simply say, Mr. President, I looked at the system. It's so broken, it's not worth fixing. Let's give everybody vouchers. Let's get them into the private sector, the world I knew. I felt comfortable with that. But as I was saying, I basically found the opposite. I found the system that was doing extraordinary things. I saw a system that If it wasn't there, veterans couldn't get that care in the private sector. So I became a strong advocate to fix the VA. And in fact, while I thought, boy, I'm Mr. Hotshot from the private sector, I'm going to go in and show those guys how to run a healthcare system, I ended up exactly the opposite, which is I learned so much about how VA cares for populations of patients that now I spend my time talking to private sector leaders about what the VA has done that really should be being done in the private sector, how you can really impact people's lives, how you can tackle these tough problems and tackle issues that frankly seem overwhelming in the greater population. So I absolutely feel like I learned far more in the VA and bringing that outside than the other way around. But I think the second part of your question is that many of your listeners probably don't follow because they don't follow David Shulkin's, personal story, which they shouldn't. Hopefully, they have better things to do. Is that the way I left government was that the president fired me by tweet. I didn't have any warning. I got the tweet just like everybody else, and my time at VA was over. But I went to VA not to serve a political party. I'm the only last cabinet member in this country to get 100-0 confirmation from the Senate. In other words, I don't do politics. I didn't sign up for political party loyalty. I came to fix the VA. I came because I believe our veterans deserve the very best that this country can offer. And that was the only reason I was there. And because the president decided to fire me by tweet, that didn't stop my desire to see that our veterans have a better system of care. So for as long as I live, I will be committed to helping improve the lives of veterans. And I continue to do that to this day. I started a think tank on policy issues to help veterans. I belong on the boards of many not-for-profit boards of veterans. And I am very engaged in many of the issues and will continue to do so.
Well, thank you, David. That's, we appreciate that. And on behalf of a number of veterans, including my father-in-law and other people, I think it's an underserved resource. Talk to us about, you mentioned the trauma of war and the pain and people trying to hide the trauma, whether it be through drugs or other things. Given that we see a war now, boiling in Israel and the trauma that is happening both to the people of Israel and to the Palestinian people, not to the terrorists, but to them. And then unfortunately, the horrific event we see in Maine with what appears, and we still don't know, so I don't want to get too far ahead of ourselves, but what appears to be a veteran who may have had some issues. How do we help address those issues to give these people the support that they need and come through these traumas? I don't want to say unscathed, but at least more whole than they are.
Yeah. Well, I think that terrible incidents like what we're seeing in Maine play out now are a little bit different than war, and I'll try to explain both. Unfortunately, this country has seen many of these horrific events with shooters who have come and just unexplainable why we continue to see these number of tragedies with no end in sight, quite frankly. But I do believe that government has a responsibility to help as much as it can in these situations. When I was secretary, I guess I was undersecretary, because I remember this was with President Obama, when the Pulse nightclub shooting happened in Florida, where a mass shooter came in to kill, at that point, gay people attending a club. The president said in his response to the country, I want the full resources of the federal government to help. I figured that's me. I'm the federal government. So I immediately authorized our mobile units of the VA with grief counselors and psychologists and medical people get on site. And the lawyers told me at VA, you can't do that. The law says that you're authorized to help veterans, not civilians, not non-veterans. I said, I don't care. Do it anyway. And what's the worst that happens? You fire me? That's okay. I'm always going to do the right thing. So VA dispensed all of its mobile units. We helped thousands of people over the next several days. There weren't as many. There is no other organization in this country with as many psychologists, grief counselors, mobile capabilities, emergency response than the VA. That's our responsibility. And I remember President Obama coming up to me several weeks later and saying, David, I just want to thank you. That was the right thing to do, and you helped a lot of people. So I do believe that when we see these events, there needs to be a full mobilization of the resources that we have in this country. On the issue of the Mideast war and our obligation to our allies, I believe when people go to war, they need to, at that time, begin to start planning for the inevitable harmful medical consequences that are going to come back, both physical as well as psychological. And in this war in the Middle East, we're seeing not only that issue involving soldiers, the Israeli soldiers, who are basically members of the civilian population, because everybody in Israel is essentially reservists, men and women of a certain age. But it's also the civilian populations of both Israel and Gaza, as you mentioned, who are getting the impact of this war. And what I do know is that if you wait until the war is over and then you say, look at what we have to deal with, it's usually too late. That it's important to do the planning and the resource allocation now. When President Biden has, in many times over the past weeks, pledged the full support of the United States to Israel and to avoid civilian conflicts, he's talking about the military and intelligence communities. And I believe we need to expand that to include the medical resources and knowledge that we have in both the Defense Health Agency as well as the Veterans Health Administration to be engaged and to help as much as we can as well.
Yeah, I think that makes total sense. The horrible things that everyone is seeing over there on many issues. Carolyn, did you have another question?
I'm curious to know a little bit more around what that planning looks like as you see war is beginning, war is happening. What does proactively planning for that medical care look like from the operational perspective and planning? Is it resource gathering? Is there more than that? Very curious to hear a little bit about your process there.
Well, first, you have to do some type of planning in terms of predictive needs. So, you need to gather your gap assessment. What are the resources we have? I believe, for example, in Israel, in speaking to members of their medical leadership, they do not have enough rehabilitative capability in the country today. I am sure they're not going to have enough psychological capabilities either. And I am sure in Gaza, they are not going to have that either. So I do believe that you can create a gap assessment of what is predicted or projected and what your current needs are. And if you don't begin to start planning for that and training people, because you can't create a psychologist overnight, especially an experienced one who has experience in trauma and military background. But you can take other people and give them training of skills to be able to start creating the appropriate type of system of care. And so you need to do that. Then you need the budget to be able to be allocated and not fighting for it afterwards. And, I think that this is where coalitions of countries that want to support, because this may be beyond what can be done locally in the region. But you have to be clear about what those needs are in order to start gathering those types of resources. And then the question is, what are the best practices? What are the learnings that we can share from the Department of Veteran Affairs, since we've done this with people returning from many conflicts? We can go back all of our conflicts. We've probably been underprepared, under-resourced. And certainly in Vietnam, we saw that. In Korea, we saw that. The Gulf Wars, and again repeated in Iraq and Afghanistan. And so we need to share those lessons with our allies.
Let me ask you a related question, David, and go back to something you said earlier. You talked about creating integrated care teams, particularly with counselors and psychiatrists and social workers. What were some of the issues, or how did you do that? What did you need to do to bring those people in and to have that work effectively?
We largely built it into the primary care system, and we created seamless integration between behavioral health and primary care, and then built around that in what's called the whole health system of care. And, you shouldn't, the way that this looks is that if you're getting your primary care, getting behavioral health care is just part of that. It's not a separate referral or go to over there across the street to the psychiatric hospital to get your care. It's all delivered in co-located sessions and in a very natural, integrated way.
That's great. Carolyn, did you want to get in the last question here?
Yeah, a little meaty one. I remember a few years ago, there was lots of talk and chatter and news around the VA choosing to move their homegrown EHR solution into a more standardized solution out there in the industry. I'm curious to know how you participated in that, what your vendor selection process looked like, and what your priorities were when you were thinking about moving a homegrown EMR into one of the main EHRs out there in the industry.
Yeah, I'll try to tell this story quickly. As I mentioned before, my main priority at the VA was to prevent veteran suicide. The single greatest period of time where suicide occurs, the rate that it occurs, is in that 1 year period when people leave the active military and when they become a veteran, that 1 year period. When you look at that period of time and you look at the issue of suicide, there's often a gap in transfer of information, so that the VA, who's going to assume care, doesn't always get the medications, the diagnoses, because the Department of Defense electronic health record does not talk to the VA's electronic health record. And when I went back to look at the issue, for 21 years, Congress and other people had been calling for interoperability between the DoD and VA. And as far as I could tell, I knew where every one of my new customers was going to come from, the Department of Defense, yet our systems didn't talk. So I knew that if I created a commission, a committee, if I went out and did an RFP, this process would take so long and be so conflicted that it would not be 21 years. It would just be 22 years or 23 years. So I did not do that. I did a process which is done only 3 times in the US government's history, first time in the VA, called the determination of findings, where I, as secretary, made the decision. And I knew I was only able to do that if it was an issue that related to the life and safety of the people I served, in this case, veterans. I felt that was the case. I felt that I needed to pick a system that DoD could be interoperable with. In fact, the same system that DoD was using. And I made that decision. I was immediately sued by the competitors. The judge asked how I made that decision. I gave 3 full binders of data and information about why the current system posed life safety issues to the risks to our veterans. And the judge threw the case out, said I was right. So we started on that path to transition to a new system of care, or a new electronic health record. That was many, many years ago. The VA has been very slow to implement that, and more recently paused the implementation due to concerns of safety in the data migration process from the Vista system to the Cerner system. So implementing an electronic health record, which I've done several times in my career, is not an easy thing to do. And I think, both Cerner and VA are learning it's not easy to do in a system as big and complex as the VA. But I do have confidence that this can be done. This needs to be done. I sure believe that the right thing to do is to continue this implementation, but it's going to have to be done very thoughtfully and carefully.
That's really helpful and insightful, particularly around the actual decision, David. I know you are coming to us from a meeting and have other obligations, so I really wanted to thank you for giving us the time to do this. We really appreciate it and wish you well in all your efforts on behalf of veterans. And thank you again for your time.
Thank you.
So we are going to wrap it up, given we had our special interview with David today. I do want to thank you for joining us. I do want to point you again to our blog, which we did talk about, which is on the pros and cons of deploying AI to confront physician burnout. I think that's particularly relevant, given everything we've seen around what's happening with doctors and the issues of strikes, and particularly same issue with pharmacists. So we are Healthcare Strategy Bullpen. As we like to say, we'd like to think of ourselves as the Rosetta Stone between technology and healthcare. We help translate the language and technology and culture of healthcare into the technology sector and into health tech and vice versa. We help you adapt and deploy your technology solutions to improve the lives of patients, including veterans. And with that, I will pass it over to Carolyn and thank everyone for joining us.
Thank you everyone for joining us. What a wonderful interview. Thanks for having me, Jeff, as well. Yep, and thanks again. And when I think about this, when I begin reflecting on this interview with Dr. Shulkin, I think about how important interoperability is to his cause, his mission, helping the veterans. And that's what Redox is here for. We want to help make data be exchanged easily, smoothly, and accurately, which is very important for the use cases that we just talked about. So very, very wonderful discussion today. Thanks again, Jeff.
One other thing I will get in before we get queued out is next week we have Dr. Steve North. Dr. North is the medical director for Eleanor Health, and he is also involved in the Center for Rural Health Innovation, and he will talk to us about using virtual care to extend care and to get to people that you can't typically get to. So we're really looking forward to that. So please do join us next week.